Carol mentioned that Dr. Liliana Oaks is our geriatrics and palliative care specialist for WellMed Medical Group. It's in the Specialist for Health multi-specialty practice, and she is a provider at WellMed's Bridges to Complex Care program and palliative care as well. She provides at-home interprofessional healthcare services to homebound seniors with chronic diseases. Let me put that into English. WellMed makes house calls. Oh yeah, she'll tell you about that as well. So if you have a caregiver, if they're a WellMed patient or about to become a WellMed patient, and it really is threatening to them and very difficult for them to go to the clinic, we come to you, which is what doctors used to do. I grew up in Cleveland. My Uncle Sal, long deceased in the 1950s, I made house calls with him, driving around his old beat-up Chrysler, and it was amazing to see how much he could do with just a touch and a look. So we're going to hear from Dr. Oaks. She participates in the largest outpatient palliative care clinic in San Antonio, helps patients who are facing threatening illnesses, helps manage their symptoms, and she can give you everything you need to know about palliative care and a whole lot more. So please welcome Dr. Liliana Oaks.
Good morning. Everybody can hear me? No? No.
Underneath. Yeah. Try that.
Yes. I cannot provide care today.
I think we need a mic tech. Ladies and gentlemen, please welcome Pete.
Well, I can go on until that gets fixed. It's a privilege to be here. I'm so excited to see a lot of familiar faces from caregivers, patients, and colleagues from the Health Science Center, the VA. I have been around a little while, and it warms my heart when I'm here seeing the passion and the interest to really work for the next step in the care of our seniors in the United States. And I'm going to spend the next 45 minutes, an hour, walking you through a journey of caring and not curing. Unfortunately, we don't cure many diseases. We cannot do it. It's part of this broken world, it's part of the disease process that we do, but we can care, and that's the reason you are here. And I'm going to walk you through what palliative care can do for you and coach you a little bit of what you as consumers of the services in healthcare can be asking your physicians to do in a world where unfortunately the revolving door is about procedures and hospitalization and pain and suffering and fragmented care, and trying to change a little bit that outlook and starting to look into the whole picture. So I'm supposed to have here, let me just get prepared here. So we're going to review a little bit what is palliative care. We're going to talk about why we need to do palliative care, the difference between hospice and palliative care. I'm going to talk a little bit about the model that we have developed in San Antonio, because this is a WellMed Summit. We wanted to tell you what WellMed is doing that the city unfortunately is not providing as fast as it should. Who will be a good candidate to receive these services, and then we can share stories, and I will be glad to hear your questions, and I will be glad to address any concerns that you have or questions. So let me introduce you a case. We're going to work this story, and we're going to analyze it and come together into understanding by making it real. So this is one of my patients that I have seen in the past year. She's 72-year-old, she's Hispanic. She has been diagnosed since the last October last year from ovarian cancer. That's a very aggressive tumor, so that's a cancer that we can do things, but we cannot cure usually because it's very aggressive. They did surgery. They couldn't remove completely the tumor from her belly. And when they did all of those tests that we doctors like to do to see if the cancer has traveled, they found that she got already small lesions in other parts of her belly. She got some other lesions in the bone and in the lung. She's very active. She's a precious lady with a tremendous faith. She got a community of believers that she shared Bible study. She got a beautiful family and grandkids. But she likes to be independent. She lives in her home, and she wants to keep that as long as she can. She doesn't want it to be, cared by anyone, and that was very clear when we met her. And then she came because when you have been diagnosed with a frightening illness, a very threatening illness, these patients are very appropriate for palliative care, because as we will learn today, we can walk that journey with the patient and the caregiver and then decide what are the trade-offs and what things can we do based on their preferences. So if you were visiting with her today, and I wanted that you discuss in your tables for 2 minutes, what would you like to know about her in regard her disease, her future, and what do you think is important to her? So discuss that for 2 minutes in your tables, and this will be a great opportunity to know your neighbor. So 2 minutes to discuss those questions, please. Okay, let's see what our collective work can bring. So can you share from your table something that one of the points you discussed? Let us pay attention here so we can move on. What did you guys wanted to share?
There was 2 things. The gentleman brought up about making sure that you had I would say a chart where the numbers are big enough and visible for them to see. And another thing is trust.
And the numbers in relationship to what medications or?
Medications, doctors, anything, I believe.
Just resources for help. So they're mentioning that one of the important things that when you're visiting with her is what other things can we offer to her, and be mindful that she can read it. What about many of our seniors? 1 out of 10 in Texas don't have formal education if you're Hispanic and you don't read or write, and then we feel so proud when we give them this stack of materials that they're going to put in their shelf as a beautiful collection of magazines. So again, very important. I love that. So how are you addressing the cultural needs of this patient and see that she reads, who reads English, what are the and trust? And that's a huge topic for another hour, but let's see what other tables can enlighten. Wonderful. Thank you. Somebody wants to share here?
First thing, the first question, what would you like to know? First thing I would say, after I tell you what my problem is, I would want to know, what can you do for me?
Exactly. You wanted to address how much the patient knows about the disease and what are the options. And not about using really big medical terminology that patients cannot understand. We want simple language. We want to speak, and are we aware that they can hear us? I have a beautiful lady yesterday that came with dementia, and Sid will talk to you and probably share stories. And my nurse came really frustrated. Oh, the patient is really demented, and she started laughing inappropriately when I talk. So when I sit with her, she speaks Spanish, and I noticed that she had a profound hearing impairment. So I put my hearing amplifiers, and a new person came in the visit. She couldn't hear what the nurse was saying, and she looked really demented. I mean, she's demented, don't take me wrong. But it was a very different relationship when she understood what I was saying. And the daughter is like, she never let me touch her. I could do a complete exam because I was able to tell her in Spanish everything that I was going to do, and she allowed me to do the care. So very important, exploring how the patient understanding is, what are their options. Very good, thank you. Here, anything different?
Yes, actually this lady right next to me put it best, is to find out what brings this lady joy, what makes her heart smile, because we want her to continue to have the best quality of life and the most meaningful part of her life with what her hobbies may be, or special family and friends to keep around to share this journey with her to the end.
Isn't it that what makes medicine so beautiful? It's not the disease, it's the story of that person. It's what they love and enjoy. It's not because they want the cancer gone. It's because they wanted to be able to enjoy what they are doing and don't be dependent to others. But in a very sick medical system, we focus on the disease. So one of the things that we're trying to do with palliative care is what you have shared. What is your story? What did you do for a living? What do you enjoy doing now? What do you think will happen in the future? And are you willing to trade off all of those things that you love because the treatment? And sometimes the answer is yes, I take the chances. Sometimes if the treatment is really bad, the patient says, I'm not willing to do the trade-off because the treatment could be worse. But how do we know about the treatment if we don't hear the story? And by hearing the story, we're discovering, and she probably mentioned that later, we can understand how to treat dementia and enjoy and make it a dignity process. And music has played a role in how we use even music as a therapy for pain management as we do in palliative care. But we need to hear the story. And what is important to the children, maybe the values and the quality of life and their goals are going to be different, but it's about hearing everyone. So that's very critical. Okay, what about this table? You love to talk.
Oh, I'm a talker.
Yeah, she hated, but...
Yeah, I talk all the time. Kath?
No.
I think we were, well, it's 3 social workers, and we were thinking more of the future of, okay, so does she have a long-term care insurance? Is she going to need, care later on, and is she prepared for that? Does she have rural, plans? Does she have a POA? All of these things we were wanting to know.
Well, what an amazing issue is when I encounter patients and families that haven't had the opportunity to talk about that. They don't even know it. If you have data and research in Hispanics, and we're in a very heavy Hispanic state, many of our Hispanics do not know what advanced care planning is. They haven't heard it. They haven't even thought about funeral plans. I mean, we live day by day. It's a culture where we like the present. We eat what we need to eat today. And this is a huge issue in palliative care. How we help not only this family to listen about their preferences, their hopes, their trust, their interests, and what is in the future, but are we ready to face challenges when plan A of being independent fails? So we work in palliative care with, I say it, plan A, plan B, plan C, plan D. We hope for plan A, and we work for plan A, but let us have plan B and C in case it comes. And that's what this table is saying. There are a lot of issues that families get overwhelmed with, especially if you have a low income, if you're struggling to pay for medications, if you don't have enough food. We have had a lot of patients with WellMed with very limited income, and there is not even food in the house. And so how you mobilize all of that. So I'm going to keep moving, otherwise we can be here for 3 hours and we cannot. But thank you for the sharing, and I bet there are more, so we're going to review that. So you are correct. Palliative care is a visit about that. It's about all the things that you mentioned and the ones that I couldn't even ask in your tables. We wanted to hear the whole story. We want everybody involved in the journey. We wanted to hear their voices, and we wanted to facilitate negotiations based on those values that the patient and the family has. So the interesting part of how we are in the United States is we have a huge number of Medicare recipients. The baby boomers have arrived and will keep growing, and we will have more walkers than strollers. Japan just sold for the first time in history more adult diapers than children diapers. So we have an aging population. That's no news to you. 67% of people want a natural death process. So how natural death happen? Well, death is part of the process of life. And it's one of the most difficult. I'm Colombian, by the way, if you haven't noticed my accent. And we see death and dying very differently. We actually accept death much more in our culture than in the United States. Why? Well, we have a lot of things to offer in technology in this country. So the news are filled with the miracle story, the transplant, first time in history. Little person received first small gut transplantation, living 14 years. Person having the third time a cardiovascular graft process in the heart. And you see all of this miracle that is part of the culture, the expectation that can we live forever? And somehow life brings death at some point. So what we're trying to do in palliative care is hearing that story from the patient. Have you ever thought about dying? Yes, no, and I hear a lot of, oh yes. I have some that says, oh yes, but I don't like to talk about it. I hear some that says no. And depending on the answer, we ask more questions. Can you share with me, are you afraid? What are your thoughts about that? What do you think will happen if you die? Are you afraid? Yes, no, why? The why is very important because the why brings something in palliative care and geriatrics that is valuable to all of us. It brings the other dimensions of the person. Not the physical pain, but we're bringing the spiritual pain, the social pain. Well, I was a bad person. I don't think God will forgive me. So then you hear the story of a spiritual pain, and we can bring other professions and other disciplines to address the spiritual pain. Well, I cannot die. My family lives in my social security check. If I die, they're not going to eat. That is social pain. So pain is not only what we have here of, I have a boo-boo, and it hurts. Can be pain in your soul, pain in your spirit, and those are equally valuable or sometimes even more complex and difficult to treat than the boo-boo that you have in your body. So it's very important that we talk about the story of that and demystify that and make it part of a natural process and prepare this family and this patient in that journey to transition based on their values in the most gentle way. Do I have patients that do not want gentle death? Absolutely. And they are very minimal, but there are people that have profound pains or fears and will choose very aggressive death processes like a resuscitation in your chest or putting chocks in your chest or putting a ventilator or a machine. And those are okay if you have a very good communication with the patient and you have spoken about options. The problem sometimes is we don't hear a lot of options and patients do not understand all of these processes. So palliative care helps to bridge those conversations with the specialty doctors and their primary care to help to have an understanding and have a fair kind of dialogue and what are those choices are. 66% said it was extremely important to them to avoid pain. Raise your hand if you like pain. Oh, she was raising her hand. No, just kidding. Nobody likes pain as far as I know. Now, if some of you like pain, you can talk to me afterwards, you know. There's something wrong with you. But the majority of people don't like suffering. And I'm talking about here, no pain only physically, but any kind of pain. And that's one of the most neglected symptoms when people are facing end-of-life issues. Horrible. So we do a great job with machines, ventilators, pressors to keep that heart pumping, the kidney. And then you read the records. I helped the state hospital to do their reviews. There is nothing mentioned about pain. And it's one of the, again, people are saying, please don't let me have pain when I die. 70% prefer to die at home rather than in the hospital. People like to be with their own pillow and their own bed and their house where they have been there for 30, 50, 70 years, where they know, especially if you have cognitive impairments, which is so prevalent in our communities due to the diseases and Hispanics mainly and metabolic things, they do very poorly with new environments. So people say, my mom does well in her home. She's not agitated. We can handle her. She goes on toilet well. When we take her to the house of my brother, she will toilet in la plantita or in the corner because she doesn't have cues in the environment, right? So when you are dying also, you want it to be in your more kind of pleasant environment, and that's home. So these numbers are telling us that we have a voice and we need to do something to meet those goals of care. And palliative care helps with that. So palliative care, it has been growing over the past 10, 15 years as a specialized medical social care for people with serious illness. So if you have a serious illness or you have a loved one that you care for with a serious illness, you could qualify to get palliative care services. Doesn't mean you are dying, but it means that that disease is going to impact your life profoundly. And it focuses a lot of things into the things that are really important for the patient, not only to get the treatment, which is vital if it's available, and get the doctors, the specialty care, but to focus on the other questions that our medical system doesn't ask very often, like, tell me about your pain, tell me about nausea, do you have fatigue, do you feel drowsy, are you depressed? Is there anything that bothers you that cannot allow you to be independent in the things that you enjoy? And I love when I introduce myself to patients because I don't say to them, hey, I'm Dr. Oaks, I'm a geriatrician palliative care, but I am the doctor that will let you eat whatever you want. And that gets me in. Wow, finally a doctor that doesn't tell me, you need to, no more sugars, cut the cakes, no more tortillas, exercise 30 minutes daily. So I'm the doctor that I work with you to make you happy. You don't want it to bathe every day? Don't bathe every day. Bathe twice a week. We get you good stuff that there are so many products these days in the market that you can apply dry so the elders can be clean, that you don't need to put them in the shower. Oh, the caregivers love that. Oh, really? I thought they needed to be everything. No, their skin gets bad, and you get your gray hair and ulcers because you want your mom to take a bath. And so palliative care is that specialty that works with families about what is important to them. And sometimes the important to them means we need to stop pills. Oh, they love that too. I don't need to take that. Not anymore. You are 95. The statin, the cholesterol pill already did what you needed to do. Do you really want it? No. Okay, take it out. That is what we focus. What are the trade-offs? Where we are in the journey. We're not moving anymore into prevention of all of. We're moving into, well, if you don't take the medication, now you can eat that pie, or you wanted to eat that ice cream, or whatever you have been removed from that you miss so much. Don't take me wrong, I love to treat diabetes, and I like those hemoglobin A1Cs to work accordingly to the frailty of the patient. Don't think that, like, what a doctor is that, Dr. Oaks? What I'm saying is palliative care help the physicians to say, oh, the goal of care is different. Can we liberalize the diet? Can we stop some meds? Can we allow the patient to do things because they're going to be dead in 2 years? So how much it matters to take and all of those guidelines of medication. So the trade-offs are completely different. And I love that we don't work by ourselves. So geriatricians and palliative care doctors work with other disciplines. So we are very heavy into our social workers. We're very heavy into our nursing staff. We're really heavy supporting a spiritual support through chaplaincy or connecting families through their churches or pastoral care if appropriate. And we meet together every week and we talk about, what are the things that we found? What are the roadblocks? Who will need more services? Who is ready or fighting a natural death process because there is a spiritual pain. So again, we work as a team, and each individual in each discipline has a tremendous power and a voice so we can honor the patient's wishes. The World Health Organization has tons of other things in the definition of palliative care. The one that I wanted to mention is, again, affirms life and regards dying as a normal process, enhance quality of life. And this is the biggest one. Let's see. The idea is that we're coming too late into the ballgame. That's the sad part, and we're trying to change that by doing cutting-edge processes like in WellMed, where we are trying to educate our own community of primary care doctors and specialty clinics that is not when the patient is dying at the hospital, which is appropriate, but it's too late. So I'll give you an example. If a patient has congestive heart failure, this is the second admission this year, we want that patient to be seen by us. Congestive heart failure is a disease that has ups and downs. And every time that there is a down and the patient gets admitted, more functional decline comes. and more difficulties are with that patient. So we don't want the patient when he's already with 10 medications in ICU to, call palliative care, which we get called, the Optum doctors and palliative care gets called. But we want that patient when they are still strong, when we can talk about depression, when we can talk about nausea, when we can talk about drowsiness, and we can hear from them who is going to speak and be the voice that we were talking about, the medical power of attorney, choosing somebody that knows them well, that can speak for them when they cannot speak, and how they see and view death and dying, and what they understand from the disease. Many of our patients do not understand congestive heart failure. They think that they get better or that they are not going to get worse, so we can help them to trace the roadmap and tell them what to expect in the future so we can have a plan. Again, plan A, stay home, be independent, don't be, cared by the... But let us also plan B, plan C, and plan D. If we never use those, we never use those. But if we need them, the families are not surprised. I encounter a lot of patients that after their loved ones died and nobody ever did this, the memories are horrible, meaning you, the caregivers, are going to be living with those decisions of your loved ones. And when you live with those decisions, sometimes the memories can be very hard if we in the healthcare system cannot help you or provide you with options. And I have here things like, if the doctors would have been honest with me, I will never have taken that chemo. I didn't know that treatment was going to destroy completely other organs, and now the cancer is treated, but I don't have a quality of life because. Or families saying, wow, we keep going, and instead of enjoying the things that were important to us and closing the memories and building the memories, our memories are at the hospital in pain, putting needles. Why? Because we are not doing what we need to do, which is help you to consider the options. So what is the difference between palliative care and hospice? Palliative care can be given with any aggressive treatment. So Miss RR, in her story, developed ovarian cancer. She met with her oncologist and said, I want the surgery. I wanted to get chemo. This cancer required 4 rounds of 4 potent medications. And she said, I understand she has cognition that allow her to make those decisions. That's very important. You need to, we always hear if the patient understand how sick they are. Because sometimes they don't, and it's due to cognitive impairment or other issues. So in that case, again, the decisions are going to be more toward the person that will represent them. But in this case, she knew very well the name. She struggled with the name of the cancer because it's a really difficult cancer to pronounce, but she knew what she was facing. So she came early, and her job wasn't to tell her to stop chemo, it was to hear her story. What you want, and let us help you, or let us prepare for the chemo. These are going to be the symptoms. These are the medications that we will collaborate with the oncologist. And she came, and she also talked to us about who she trusted that will be her voice. So we did the medical power of attorney, who she knew, and we met with that person, and do you know your mom? You will be representing your mom. This is a very important concept for all of you as caregivers. When we are giving that responsibility, it's not to choose what we want. Is to get to know our loved one so well that when we need to bring that person into a crisis and that our loved one cannot speak, and we call that in palliative care, we bring the person into the room. And the question is, if your mom will be here today, or your dad, like in this case, RR, or your dad, if your loved one will be sitting with us today, will she want it to have A, B, C, or D? Which she would like to be kept alive in the machine? Do you think that she will say today to do this procedure or not? So that's the reason being a caregiver and a medical power of attorney carries a lot of responsibility, but the more than you can do your diligent job to understand and know your loved one values, that decision makes easier. And it's much easier when we, the healthcare providers, facilitate the dialogue, and it's written in documents, and it's written in the record. So if by any confusion or emotion you do not know what to do, we will guide you, because we get to know your story too. So again, it's a very active collaborative process. We can focus, again, patients' goals. We do not require physicians order or referral, so families can request. In WellMed, well, the primary care is referring that, but you can tell your primary care, I want my mom because this disease to get a palliative care evaluation. Hospice care is a benefit and a service paid by Medicare. Okay? Because it's a service and a benefit by Medicare, it's not a place. Even though we have inpatient units where a patient could be admitted if the symptoms are really severe, hospice is a service that can be delivered wherever the patient is. So that's a big difference. People say, I don't want my mom dying in hospice because they're going to take her away and put her in a place where people die. That's wrong. Hospice is a service, is a benefit, and because Medicare pays for that benefit, that service, there is criteria. So when you are in hospice, the criteria is clear. One, you need to have a terminal illness. That means you are going to die from that disease or two diseases. Sometimes two diseases can be very close together. You are going to die from those diseases. You need to believe that the physician that is making the referral or the thought process about that is thinking that the person is going to be dead in 6 months. So how we know that? Because we think, am I be surprised if this patient will be dead in 6 months? If the answer is no, I won't be surprised. That's probably a good guideline that this person is facing a terminal illness. And that prompts us physicians to say the patient will benefit from that. There are a lot of diseases under Medicare, from neurological diseases, cardiovascular diseases, end-stage renal disease, cancers. All of those have a specific criteria and usually show somebody that is really sick. They depend on all the care the majority of the time. They are having multiple infections. They are showing other signs of complications. So again, each disease has criteria. And we need to refer. It's a physician referral. So for palliative care, you don't need the physician to refer, and WellMed you do because you are part of our system, but in general, you don't need a referral in palliative care. So I wanted to ask you, is that clear? Because that's where I see a lot of confusion, and I'm going to show you a graphic for the people that are visual that can help you to see, but any questions so far? I have a question. Sure. Very good. So there are different models in how palliative care is being paid. In WellMed, because the government give us a lump sum for each one of the beneficiaries, we have opted to add it and get paid from the same pot. And the interesting thing from the business perspective in the country is that when you offer palliative care, we don't make money, we save money. So when we work with patients and family, we are helping them to avoid unnecessary imaging, unnecessary hospitalizations, unnecessary things that were not appropriate, and that's how palliative care gets sort of in the system reimbursed. It's mainly right now in the United States a hospital movement. So if you see palliative care is mainly at the hospitals. Baptist has the best palliative care inpatient service in San Antonio. There are other places that announce that in the private sector. VA has had the longest palliative care in the city. They train the fellows that go to this hospital, by the way. So VA takes all the credit because I used to run the geriatric program and Sandra Sanchez-Riley ran the palliative care program. So we used to produce the geriatricians and the palliative care in the city. So the VA is the academic model for palliative care. But in the community, Baptist is being filled by physicians that are trained on this. University Hospital has 2 faculty in palliative care. The other hospitals have a website, and we have called, and you don't reach anyone. So again, if somebody's from Methodist, get busy and get your show together. But what I'm saying is all hospitals should have this program. Because why we need to choose all the systems should have the best practices in the cities because all seniors should benefit from this, or younger people. I mean, palliative care is seen in people in 30 years old, women with metastatic breast cancer. You know, young people get very sick too, very appropriate for palliative care. So we see those in UHS, University Hospital. Is somebody here from UHS? Palliative care, unfunded, younger people, very aggressive tumors. You bet they need to get palliative care. So the family, the children, the bereavement, it's a very intense process. So palliative care has helped tremendously in UHS. So the models get paid because hospitals said, oh man, if I get these palliative care processes, patients are happier. We don't need to do all of these horrible things to them. So again, they come in, the ICU admissions decrease. So there is a lot of data on how palliative care helps economically to sustain these programs. Okay, so this is a very good phrase to remember. All hospice care is palliative, but not all palliative care is hospice. Because again, imagine, this is the image I wanted to show you. The old model, we used to have life-prolonging care, hospitalizations, tons of treatments, all of that is appropriate, if it's appropriate, and then the person is really going to die, we need to send them to hospice. They have a lot of symptoms that were not addressed, they were unhappy, depressed, nausea, vomiting. The model in the bottom is saying you can have a life-prolonging care with whatever your choices are for that care. Curative treatments, if that's appropriate, but we will be shoulder to shoulder. At some point, we will do more care than attempted curative treatments, and then we will help that person to transition and said, we have done everything to try to ameliorate the disease. We're switching gears to provide much more care. Equally important, like ICU, is when we do palliative care. So it's when people said, oh, you're giving up on me. Opposite. I'm actually going to give you much more than an ICU will give you, because we're going to talk to you about what is important to you and your family. So you see, so never make this, oh, you are giving up on me, because we never give up on humans. We shouldn't. Nobody should die alone. And there are movements in the country in hospitals where you should die with somebody and not lonely, unless you choose to die by yourself, which there are patients that do. The majority like to have somebody next to them. Very few will say they wanted to die lonely. So again, think about this early. This is what we're targeting, and you and the caregiving movement can help us. We wanted to get these palliative care services early in conjunction with your specialty doctors in your primary care to improve your quality of life and symptoms. So how this work pretty much in WellMed, because that's what I wanted that you understand. There are different models. Palliative care is starting to move in the outpatient clinics, and the majority of the models are coming from managed care. Why? Because there is much more case management and case coordination in managed care. But there are some other models that with the accountable care organizations are trying to look at how not only you offer this in the hospital, but can we move this in the community so people don't need to necessarily be in the hospital to get a consultation. So approximately in the fall of 2013, Dr. Elizabeth Glazer, who is our medical director, initiated a pilot project opening a clinic and admitting patients that needed palliative care, and a subset of them also were very frail and homebound. And you know, you have been there in the winter, they have dementia, I don't want it to go to the doctor. Why you're going to get me in the car? They're going to kill me there. I don't want it, and the caregiver is trying to drag them out of their house, and bathing, forget about, just put perfume because the bath is not going to work. So it gets really challenging, right? So by doing the house call program, they can be with their hair like this, and they can wear their pajamas and their sleepers, and we go and meet their needs at home with the nurses, the social work, and we can do x-rays at home, we can do IV fluids at home, we can, did I say draw blood too? We do everything at home. We do wound care in the home. And we also, again, work with the patients and the goals of care, what they want, what they don't want. We try to help them to bridge spiritually. Is faith important to you? Some of them have been, unfortunately, neglected by their spiritual communities because churches didn't know they couldn't live anymore. That's very painful when you see isolation. And I see Ava Care here with Timothy Spigman that is trying to move and get together all the churches to try to go to the houses of the seniors and do programs that can help them spiritually. 5 minutes. He's a bad guy. 5 minutes. Okay. So we did all of that with RR. We asked her about how she understands. When you ask a family and a patient how much they know about their illness, what is important about her life, and what is their definition of quality of life, then you can talk about the trade-offs. And that, based on that, we can make recommendations about code status and natural death, because we understand the story. So in our case, she wanted to be independent, don't be a burden. She chooses her daughter. And she says, I understand everything you are saying, Dr. Oaks, but I wanted to give it a try to the chemo. So she went through the chemo, and all her bone marrow, her tuétanos, like we say in Spanish, shut down. She required an imminent transfusion. She developed chest pain. She hated it. She went back home with a walker. She wasn't using a walker. So we meet again. Now at home, she says, she used to come to my clinic, and I said, I'm ready for your program. I don't want it to leave my home anymore. You know, I'm very fatigued. So we continued the conversation, and then she says, I don't want transfusions. I'm done with the chemo. Well, the kids came. How you're going to give up, Mom? You cannot do that. Let us bring the doctor. So we did a big family meeting, and the children understood from the oncologist that she was going to be cured. They didn't understand that what he was offering was what we call palliative chemo, shrinking the tumor, give her a few more months, and now that the chemo failed, she cannot receive more chemo. So they're going to offer her radiation, which is a potent wave to all the intestine that will also damage the rest of the intestine and the bladder, meaning she will pee all the time, she will develop pain. She didn't have pain so far. So we have a meeting, and we talk about the roadmap, the future. And they were surprised. They said, we understood a cure. That wasn't curative. So we are still working with her. And she said, I don't want any more transfusions, but I wanted to meet one more time, a CT, to see if the chemo did anything. We honor that, absolutely. Get the CT. And we will be meeting next week. So come next year, and I give you a close on the case. So your doctors can refer to us. We have right now, WellMed works with Optum. We have 3 MDs and 1 nurse practitioner. And we have all the areas in the city, palliative care clinics, where your loved one can get a palliative care consultation. And if your loved one lives inside the 1604 loop, you bet we take you at home. We cannot go outside 1604. I drive between 60 to 100 miles a day. And the goal is each physician will carry 250 patients, the sickest of the sickest. And I love it. I love all of you. I love complicated seniors. I love the cases where everybody says, well, I don't know what to do. I do. You just let them eat ice cream and they love you. But, don't share the secret. So who should be referred? Anybody with a bad illness, comorbidities, a patient that has multiple hospitalizations, ER visits. A lot of what we do in WellMed and hospitalizations are related with patients that have not been diagnosed with dementia. And we keep giving them prescriptions, and they will collect the bottles, they will collect the prescriptions, they won't follow the treatment, not because they are poor compliance. They just cannot do it. So we have addressed the dementia issue in WellMed and try to work more with the primary caregiver. See, he's next to me. I know you. You're here. Okay. Just these are resources and the slides for you. You can click those links and get to know more about palliative care. And again, more resources. I already told you that. I wanted to close with a short video. It's 3 minutes, I promise. No?
At the end, we're doing a panel.
Ah, okay.
You want to stick around?
I have 2 patients at home that I need to see. Okay. He will answer the questions for me. So, okay. Well, if there is time at the end, he can show you the video. Okay. Thank you so much for having me.